is...
Sorry, Ansell, just wait a couple of seconds.
Oh, yeah.
Now.
Okay, so my research is in generating synthetic planning CT from diagnostic CT using deep learning to expedite palliative radiotherapy. So the aims of my research is to create a synthetic planning CT from diagnostic CT images to expedite palliative radiotherapy. The standard radiotherapy workflow is the patient first comes in for a diagnostic CT followed by a consultation. Then they go home. If they need to undergo radiotherapy, they go back for a planning CT. Then they go back home, wait for the treatment planning to be done based on the planning CT images. Then they go back to the hospital for a treatment delivery. So this is not very convenient for the patient because they have to go back and forth to the hospital. So in the proposed workflow, we can remove the need for the patient to undergo a planning CT by creating the synthetic CT images from the diagnostic CT images. So the reason we need to create the planning CT images instead of just using the diagnostic CT images is because diagnostic CT uses a curved couch. As you can see in the image on the right, images A and C has a curved couch with the patient's anatomy following the curved couch. Meanwhile, in radiotherapy, we use a flat couch. As you can see in images B and D, there's a flat couch and the patient's anatomy follows the flat couch. So we need to model this difference when creating the synthetic planning CT images. So the main purpose of palliative radiotherapy is to provide pain relief and to improve the quality of life of the patients. This is why the standard radiotherapy workflow is not ideal, especially for remote palliative patients where they need to travel long distances to go back and forth to the hospital. If we can remove the need for the patients to undergo a planning CT, we make the process a lot more convenient for them, which improves their quality of life, and this ties back to the main purpose of the treatment. So according to the Australian Institute of Health and Welfare, palliative radiotherapy forms quite a significant percentage of radiotherapy courses in Australia, which is around 40% in 2018-2019. Also, we can see that remote patients have a disadvantage compared to patients living in high socioeconomic area in terms of average waiting time. They need to wait for an average of 12 days instead of 8 days for patients in high socioeconomic areas. So the data set that will be used is going to be around 60 DCT to PCT image pairs. And this data set is going to be used to train a diffusion model, which is currently considered as the state-of-the-art model in generative AI. And because the diagnostic CT and planning CT can be thought of as like a deformed version of each other, we can train the model to output a deformable vector field. As you can see in the image on the right, the deformable vector field can be used to deform the diagnostic CT to create the synthetic planning CT. So in the image on the bottom, we can see how a diffusion model works. So it works by having a forward diffusion and a reverse diffusion. The forward diffusion introduces Gaussian noise to an image over a series of time steps, and the reverse diffusion attempts to remove the noise from the image, starting from a noisy image to get a nice noise-free image. So there are a few performance metrics that can be used to evaluate the model's performance. In terms of image deformations, some of the most common ones are dissimilarity coefficients and Hausdorff distance. Also, we can perform dosimetric comparisons to compare the synthetic CT with the ground truth planning CT using those volume histograms. Uncertainty quantification is also a very useful thing to do, especially when there's quite a significant consequence of inaccurate predictions. The idea of uncertainty quantification is that when the model outputs a prediction, it also outputs how certain it is with its prediction, so that if the model is not very certain of its prediction, it can flag the result, and the clinicians that see the result can make a more informed decision of whether or not to use this prediction from the model. So some of the methods for uncertainty quantifications are Monte Carlo dropout, deep ensemble, and bagging. So in the context of simulation-free radiotherapy, there are a few different approaches. The first approach is adaptive radiotherapy, which is using diagnostic images to create the treatment plan. And when the patient comes in for the treatment, the treatment plan is adapted based on the CBCT taken on the day of the treatment. This usually requires recent diagnostic imaging, usually within 4 to 6 weeks. And the main disadvantage of this is increased treatment time, because the patient needs to wait for the plan to be adapted to the session CBCT. Another disadvantage is that this can increase the workload in the department. For example, some of the studies require a physicist to attend each fraction, and other studies found that most patients require contour adaptation by the radiation oncologist, which needs to be done immediately after the CBCT if we want the treatment time to still be acceptable for the patients. So the second approach to simulation-free radiotherapy is by using the diagnostic CT directly without adapting the plan. This also requires recent diagnostic images, usually within 4 weeks of the therapy. The main disadvantage of this is the strict eligibility criteria. As can be seen in many studies, they tend to have a very low eligibility rate, and having a low eligibility rate means that not many patients can be treated using this technique. So the third approach, which is the approach I am going to use in my project, is generating synthetic CT from diagnostic CT. So there are a few papers by Husang Nejat in this topic. In their papers, they used a couch removal algorithm to temporarily remove the couch from the CT images, so that the model doesn't need to predict how the couch deforms between the diagnostic and the planning CT. So this has been shown to work well to treat pancreatic and lung cancer, and this can also expedite the workflow from 4 weeks to only 2 weeks from the diagnostic to the start of treatment. They also evaluated how the weight loss affects the CT images and found that weight loss is negligible for patients with low BMI or short delays. But they found that weight loss is significant for high BMI patients with long delays. So there's also a paper that discusses different approaches of using diffusion model to predict anatomical changes. They use this model to predict anatomical changes between CBCT, between fractions in radiotherapy. So the first approach they use, they call it the image model, which is a pixel-to-pixel image translation, where the model directly generates the CBCT images. The second model is the deformable vector field model. So the model generates the DVFs, but this model needs an external image registration algorithm to create ground truth DVFs to train the model. So the third approach is the hybrid model, which also generates the DVFs, but solves the problem of having to use an external algorithm. So this model doesn't need an external algorithm to generate the ground truth DVFs. Instead, this directly uses the CBCT images as the ground truth. So there are a few problems that I expect to encounter in my research. First is with patient weight loss. As you can see in the image on the right, patient weight loss can result in quite a significant geometric deformation in the patient's anatomy, especially in the anterior region. And this might be difficult for the model to learn. And another problem is with the computational resource. Training a deep learning model is computationally very expensive, and also in diffusion models, image generation can also be time consuming because the images will have to be generated through a series of reverse diffusion time steps. And the more time steps we use, then the longer the image generation is. So the computational resource needed for this research will be provided by the Department of Radiation Oncology here at the Sir Charles Gairdner Hospital, and ethics approval has been granted for this research. So these are the references, and thank you.
Excellent. Thank you, Ansell, for that presentation. So we'll now open it up for questions. Shahid, it looks like you have your hand up.
Yes, thank you. And thanks, Ansel. I have a question about the criteria you're using for your study. So you briefly mentioned what limits are there in the publications and which patients could be used, but
Yes.
what are the ones that you are considering? Like which patients, sorry.
Right now, the patients are where the data set that's available right now is around 6 weeks difference between the diagnostic and planning CT. And I'm not really sure about the other criterias, but that's the one that I know there is right now.
Okay. My other question is, we have Joel's project at the moment,
Yes.
which is on a similar topic.
Yes.
So how is your project different to that? And I've seen you have images that you have given credit to Joel's study, but you haven't mentioned that if you are continuing on Joel's work, then it hasn't been acknowledged.
Oh, yes. So it's like an extension of Joel's project. So
Yes.
the difference is that I'm going to try a different approach. So Joel is doing a GAN, pixel to pixel GAN,
Mm-hmm.
and I'm going to try to make a diffusion model with the deformable vector field.
Right. So it had to be in your talk because
Yeah.
you need to acknowledge the work of others. Okay?
Yes.
All right. Thank you.
Thanks, Machine. Martin?
Thanks, Ansell. You really showed a good understanding of things. Just one question. One of the bigger factors that influences the change in anatomy is the change of the couch top.
Yes.
Why are different couch tops used in the diagnostic and in treatment?
Oh, yeah. So in diagnostic, we usually want to make the couch as comfortable for the patient as possible. That's why we use a curved couch. But the accuracy of this is usually not enough for the treatment. So in treatment, we usually use a flat couch, which means that we usually need to do a planning CT again with a flat couch for the treatment planning.
So it's the accuracy required that governs the use of a flat couch top.
Yes.
Is that correct?
Yes.
Okay, thank you.
Thanks, Martin. And Roger?
Ansell, thank you for explaining your topic so well. I've got a question which you may have even given the answer to, and I apologize if it was in your talk. But why is the eligibility rate for diagnostic CT so low? Is it because of the range of cancers that it doesn't work for, or is it are there exclusions based on particular anatomies of the patient, or changes in their physiology like weight loss and so forth? What's the main reason?
So yeah, those are some of the reasons. So the length of the time between the diagnostic and treatment is one. For this research, I believe they only consider palliative patients, but they still have this low eligibility rate because some different techniques used in the diagnostic imaging that's different from treatment planning, like planning CT techniques with the curved couch, and also some mention about like respiratory gating for lung patients, which can also be different.
Okay, thank you very
Yeah.
much.
Excellent. Thank you for the questions. Thanks, Ansell. I think we'll end there. Thanks very much
Yes.
for the presentation.
Thank you.